This is Pat Walter from the Surface Hippie website, and I'm in Baltimore, Maryland, with Dr. Gross from South Carolina. Hi, Dr. Gross.
Hello, Pat. How are you doing today?
Good. I'd like you to tell some of the potential patients what has been your experience with hip resurfacing, what type of device you use, and a little bit about the cementless devices.
Okay. I began hip resurfacing in about 1999, so I've been doing this for well over 10 years, and I've performed over 2,400 resurfacings. You asked about uncemented. I exclusively do resurfacing with uncemented devices, and I pioneered that about 4 years ago. We started that, and we've got about 1,500, almost 1,400 uncemented resurfacings at this point. My practice is really dedicated to hip resurfacing. About 80% of my cases are hip resurfacing, and I do some total hips and some complex revision surgery and some knee replacement. But my primary interest is hip resurfacing. I'm involved in implant design, I have been, and primarily also in technical improvements in hip resurfacing. So my focus is to make resurfacing better. And in this present climate, it's a little bit difficult because there have been recently some negative reports about hip resurfacing and metal hip replacements. And rather than migrate away from those as other surgeons have, I'm focusing more on figuring out why we have the problems and trying to correct them. Because really with any kind of artificial implant system, there are mechanical or technical wear problems, and it's really not clear yet which ones in the long run are better, particularly in very highly active younger patients. So in hip resurfacing, for a long time, the common wisdom has been patient selection. Paper after paper touts this. So we find out which patients have a higher risk of problems, and then we say, well, maybe we shouldn't do resurfacing in those patients. We should do total hip in those. What always gets missed in that analysis is, what about if you did a total hip in that patient? Do they also have higher rate of complications? Because it doesn't necessarily follow that they'll have a great result with a total hip. And there's some evidence to support that, particularly with, for instance, hip dysplasia. They have problems with either operation. So my philosophy is to improve the implants and the techniques and to make resurfacing work for more and more patients rather than just try to focus on the small group that has the very best results with resurfacing. And it's kind of a philosophical decision. With hip arthritis, the main problem is really a loss of the cartilage surface of the joint. That's the basic problem. And there's usually, in younger people particularly, also some deformity of the bone around that in the socket in the femur that often predisposes to that problem. So it seems logical to me to replace the surface of the cartilage and do some minor changes to correct the deformities back to normal. And I think in most cases, you don't need to do radical surgery of cutting the head and neck off and putting a stem in to accomplish that. You can correct back to a normal biomechanics quite well with the resurfacing. So that's just a matter of philosophy. Hip replacements also work very well. It's not really clear yet in the end which will be the best operation eventually. Let me just talk about some of the advances that we have made in hip resurfacing that have not really clearly made it into press yet. For instance, one of the early problems identified with hip resurfacing many years ago in one paper was that cysts in the femoral head, bone loss in the femoral head due to arthritis, predisposed to a higher failure rate. So in many papers and in many recommendations that you see written, that they say if you have cysts in the femoral head, you shouldn't do resurfacing. Well, I've never really believed that. Those early cases, the cysts were holes where the bone was removed, the tissue was removed, there were holes in the bone, and then they were filled with cement as you cemented on the component. And instead of not doing those cases, I thought it would be better to bone graft those and then cement over them, and now we use uncement techniques, so we don't even use cement. And I've kept track of all those cases, and I've submitted for publication a paper that shows that the risk of failure on the femoral side with cysts is no higher than if you don't have cysts. So simply by bone grafting them instead of filling those cysts with cement, we've been able to achieve, in a much larger group of patients in that original paper, no higher rate of failures on the femoral side with cysts. So I think that pretty much debunks the idea of femoral cysts being a negative risk. The second issue are femoral neck fractures. Those occur early in the first 6 months. They occur in resurfacing and never in total hip replacement. In total hip replacement, you get a fracture of the shaft, and that's well documented that there's a certain percentage of that happening. But many of the papers on hip resurfacing were focused on on the risk of femoral neck fracture in women and older patients who are more prone to it. Well, and patients with rheumatoid arthritis, and perhaps patients with cysts. And so the idea was, well, worse bone quality in the femur led to the fracture. That's a logical idea. Well, we actually did a study looking at that. We measured bone density, and we were able to analyze that the true factor is bone density. So these other risk factors are just markers for what's underneath. It's bone density. And we were able to very clearly stratify bone density as a risk factor, and we are able to tell people by their bone density what the risk is of a fracture. And even better than that, now that we know that, we can then treat those people with weaker bone with bone strengthening agents. And we've used Fosamax, bisphosphonate, and we have a group of patients who were previously stratified at an 8% risk of femoral neck fracture because of weaker bone, and we treated them with Fosamax, and we have 0 now in that same group of patients. So there's just another example of how changing the treatment and looking carefully at why these problems are occurring, you can resolve these problems and eliminate those complications rather than just abandoning those patients. Say, oh, you can't do resurfacing, you got to do something else. And incidentally, I know of no good data that stratifies bone density with femoral fractures in total hip, but it's likely to be the case also. I mean, it's just logical. If you have weaker bone and you stick implants in, you're going to have some higher risk of breakage. The third problem has been dysplasia. Third example of that. Early on, I noticed about a 5% failure rate in socket fixation in dysplasia in my patients. Well, the problem is dysplasia patients have an oval socket. There are varying degrees of that, and it's hard to get a round socket without screws to work to get fixation in dysplasia, and that's the problem we encountered. So a new socket was developed that had some spikes on it, so you don't, instead of putting screws through it, which you can't do in a resurfacing, we have one with spikes. We started using that in all the severe dysplasia cases in about 2007, and since that time, so in 4 years, we've not had a single failure of cup fixation in the dysplasia cases. So another problem solved. So we're just going down the list. It's femoral cysts by bone grafting, femoral neck fractures by stratifying patients and treating them differently if they have weaker bone, and now dysplasia socket fixation. The next big issue that's now come up really in the last few years is this issue of wear, and this has really scared a lot of people away from metal bearings. And one of the early studies that really made a lot of headway in the press or convincing people was a study that showed that these seem to be mysterious inflammatory reactions that they couldn't correlate with any particular component position, and were able to correlate it with women had a higher risk of it, dysplasia patients had a higher risk, and those with smaller implant sizes. But numerous surgeons now have been able to figure out that the primary problem really is how we place the cup. And still there are some patients who are at higher risk, and it's not clear why. Maybe there are certain groups of patients like dysplasia who have a more deformed socket where we are more prone to put the cup wrong. We haven't really figured this out, but that's my suspicion because we use bony landmarks to place the cup. And there are very few studies that show how often we place the cup in the supposed ideal range. We all sort of have this picture of an ideal range. I think there's a lot of work that still needs to be done to really figure out what the ideal range is. The studies so far have been very crude, but there was one recent study published saying that cups are placed too steep in about 30% of the cases. So out of range in just how steep they are, 30% of the cases in total hip replacement. Well, and if you don't use metal bearings, you don't have the metal wear problems, but you have breakages of implants, you have plastic wear problems, you have dislocations. So with metal implants, it's clear you get wear problems. You don't get dislocations if you put the cup too steep. But it seems to be, research study after research study seems to show it's cup position, particularly if you put the cup too steep, and to a lesser degree if you put the cup too tilted forward, or what we call anteversion. And Kohn de Smet has done some great work in that regard. David Langton and Tony Nargol in England, and Justin Cobb has done some CT studies. And it's becoming very clear that the initial studies were wrong. It's not mysterious, it's cup position. So our focus really needs to be on positioning these cups more accurately. And in that regard, we started doing that in 2007, and a study has just been accepted for publication where we've been able to dramatically reduce the number of cups that are too steeply placed just by using X-ray techniques in surgery. And we've refined those techniques to the point now we've just looked up our last 400 cases we've done over the last little over a year. And we take a very, very challenging look at that cup by taking a standing x-ray. Many people take the x-ray in a lying position. I think that's a mistake because people change the way they position their pelvis when they stand up. And I think that's the critical position. That's not proven yet, but I think that's the challenging position. And we have standing x-rays on 400 straight patients with no cup angles above 50 degrees. So with the refinement and x-ray technique, you can get close to perfect in avoiding too steep of a cups. And I think that will then translate into even fewer wear problems. The other cup position that's critical is the tilt, the anteversion. And that's much more difficult to measure on x-ray. Some people think they can. It's very difficult, particularly with these large bearings. So we have some other work in progress on how to do that. It may take CT studies and so forth. So that's still a factor. We still need to do more critical work in getting that anterior tilt exactly right and reproducible in every patient. So if you have a study where you have an average cup position, that's not good enough. What you really need to know is how many are out of the range, above the angle. And again, just a study published in Total Hips this year, a very large study from a large center, showed 30%, even after intensive teaching, the cups were too steep. And now with x-ray techniques, in the last year, with 400 cases, we've had no cups above 50 on a standing x-ray. So with refinements and techniques, I think we can get there and get good cup positions. And I think that's the way we're going to eliminate these wear problems. But we still need years of work to demonstrate.